Good afternoon, Peter Goertz. I'm a psychiatrist. When your patient dies by suicide, last week I was sitting at work on a regular day and I get a message in the computer, so-and-so's mother called and would like to speak with you. And I called the mother and she told me my patient had died. And she said she felt it was by suicide and that it had been ruled a suicide. So not the kind of phone call one looks forward to as a psychiatrist or as a person to hear about a suicide. And this patient I'd been seeing for quite some time, many years, on and off. He'd sometimes not come in. At one point, he didn't come in for over 2.5 years, I think. So how do you feel when you get a call like that? Sad. I felt sad. And it's interesting, I had actually had a good feeling about him during the last 2 visits that I'd seen him. And he had seemed to be going in a reasonably good direction. So other feelings can come up potentially: anger at yourself, anger at the patient, worry about legal issues, worry about how peers might see you, worry about losing your job if your patient dies by suicide. And that could even potentially get to the point where a psychiatrist might even consider a career change. As far as the legal aspect, over the years, my experience has been it's wise to be a human being, so be who you are. Talk with the family like a human being and be upfront. And overall, with potential legal issues, my feeling is that the relationships are key. So your relationship with family, with the patient, of course, primarily, with friends of the patient, all that I think is very important. If you have good relationships with the patient, family, friends, that goes a long way in preventing legal issues. And you can even make major mistakes and the patient may not hold it against you if you have a good relationship with the patient. So all this, of course, is another wake-up call. As a psychiatrist, we want to take our patients seriously, remind ourselves things can go very wrong. People can end up dead. And it's us who is charged with the responsibility to try and make sure things go well. So it's a sad thing. You don't necessarily feel good about yourself when you hear about something like that. Depression in itself can be a risk factor for suicide, of course. So we want to take depression very seriously. Not taking medicine, another potential risk factor. If someone doesn't take their medicine, the medicine can't work. And they can get very depressed, not just from not having the medicine, but potentially even from withdrawal from the medicine. Some medications like Effexor can cause a pretty difficult withdrawal syndrome: dizziness, nausea, insomnia, feeling agitated, like you have the flu. So all that doesn't help depression. If someone is paranoid, if you have a paranoid patient, that can be dangerous. If the patient feels cornered, for example, they may be violent towards others or even kill themselves if they feel cornered. So paranoid feelings can be very dangerous at times, but you never know because we have so many paranoid patients and they're not necessarily dangerous, but it can happen for sure that someone who's paranoid feels cornered and then acts violently towards other people or towards themselves. Substance use, alcohol, drugs can be a major problem in patients and can destabilize their mood and end up decreasing the threshold that they have for suicide, for being suicidal and then acting on suicidal thoughts. We want to try our best to make sure that patients who might be dangerous do not have access to firearms. We cannot ultimately control people, but we could, for instance, try and make sure the family ensures that the patient does not have access to a firearm, try and ensure that friends are involved, and try and make sure the patient doesn't have a gun. Social isolation is another risk factor for suicide. And there are other risk factors I won't get to mention today, I'm sure. But someone who's socially isolated, we want to try and work on that if possible, get them more engaged with other people. What do I learn from a situation like this? Humility. Humility is a good thing. We're human and we don't want to feel like we're better than anybody else. And we definitely can all make mistakes. We're not perfect. So humility is a wonderful thing to learn from situations like this when your patient kills themselves. And we want to try our best to have good relationships with our patients and know them well. That definitely can help in potentially preventing suicide or preventing adverse outcomes in general, ensuring that they take their medicine, but not necessarily. You might have a very good relationship with the patient and they just sometimes don't feel like taking their medicine, and that doesn't mean your relationship was bad. Tricky situations. Ultimately, in my opinion, we cannot control other people, so that means we cannot control our patients, but that doesn't mean we're not going to try our best to ensure as best we can that they do well and enjoy their lives. I mean, that's our ultimate goal, is for our patients to do well and enjoy their lives. Thank you very much.